So Trailblazers, the future of care. That's what I'm calling this session. And really, this is kind of like a keynote, but it's going to be individual presentations. And what we're going to talk about are a few things in Duchenne that maybe you don't hear about all the time. We're talking about newborn screening. We're talking about equity and access, mental health. So these are some cool topics. We'll have about 15 minutes per topic, and we're going to dive into a few areas that we don't address all the time. But we should start talking about. And these are some amazing physicians and professionals that are leading the charge with this. So I'm really proud to put this together, and I'm going to welcome my speakers to the stage. Thank you so much. Thanks, Natalie.
Just go.
You follow directions well.
Good morning. My name is Richard Parad. That's a hard act to follow, but let me introduce myself for a moment. I'm new to the Cure Duchenne community. I'm a pediatrician, neonatologist, and pediatric pulmonologist based in Boston. And I come to talk to you about newborn screening for Duchenne this morning from a background of having been involved with a cystic fibrosis story, which sort of heard from Vertex yesterday about their involvement, and looking at the history of that and trying to apply it to Duchenne. I started the cystic fibrosis newborn screening program in my state in Massachusetts in 1999, before any therapies were available. From Vertex, and by 2010, every state in the United States was screening for cystic fibrosis, and therapies appeared, and the newborn screening process was in place and ready to get patients into therapy more quickly. So I have the same vision for Duchenne, and I'll try to give you some background on newborn screening, talk to you about Duchenne newborn screening and what it might mean for patients. I'd like to thank Cure Duchenne and Deborah Miller, because this program would not exist without their support. So here are the things we'll touch on. What is newborn screening? What's Duchenne newborn screening? How can doing newborn screening contribute to better outcomes for individuals with Duchenne? How does this funded program work? And what have we done so far? And then where do we see this going in the future? So what's newborn screening? It is well, these slides are a little tricky. It's a universal public health service. It's a process, and it's offered to all babies just after birth. In the United States, there are about 4 million babies born every year. Newborn screening programs are state-based, so there are 51 newborn screening programs. They each do their own thing. Their purpose is to identify rare disorders early before symptoms develop. There needs to be a therapy available in order to fit into this system. And it needs to be important that starting that therapy early is going to improve the outcome of that child individual. There is a national panel, a federal panel that started in around the year 2000 that makes a recommendation of what disorders the state should screen for, but it's basically up to the state about what they can afford to do, what principally they decide they want to do. And each state has a laboratory that performs the testing. There are actually 3 different types of newborn screening. There's hearing screening, there's congenital heart disease screening, and there's dried blood spot screening. And it's the dried blood spot screening that I'll be talking about, and many of you may remember or may not remember your baby at about 24 hours of life having a little heel prick and having a little blood collected on a filter paper card and sent off somewhere, and maybe hopefully you wouldn't have heard anything about any problems because there are no states that screen for Duchenne, but I'm hoping that we can change that. Even if that committee, that screening panel committee decides, yes, we should get the states to offer Duchenne newborn screening, it takes somewhere around 10 years from the time you approach the committee to the time all the states are screening for this to happen. It's a very big, complicated process. So my goal has been to try to start pushing at this and get it going, since it's going to take a long time, and those therapies are all going to be lined up by the time we get there. Massachusetts, my state, was the first state to do newborn screening. It was for a rare disorder called phenylketonuria. The intervention was very simple. You had to put the baby on a special diet, but you had to start right away or else some brain injury would start taking place. And this guy down in the bottom corner, a guy named Robert Guthrie, was the father of this process. He thought of the idea, he developed the test for PKU. He thought of distributing these filter paper cards to the birth hospitals and having all babies screened right at birth, and then the concept of sending them to a central state lab with a rapid turnaround time on the results and recommendations for what to do. And on the left is just an example of, I think, Wisconsin's story. They started in 1965, and you can see every few years they add another disease on or another few diseases on, and that's how most states have worked. Currently, most states screen for somewhere around 30 to 35 disorders, and some as many as 60 disorders, but it varies by the state that your child's born in. And this process, again, in the lower left-hand corner, it starts with some little drops of blood on that filter paper. It's universal, so every baby gets this, not just people who can afford to get it. It goes to, the families are informed, they get a little pamphlet, it goes to a central state lab, and then the lab is also responsible for following up to make sure that the results are acted on. As far as we know, there's an estimate in the whole world, newborn screening does happen in other countries, about 100,000 babies with rare disorders are picked up early, started on appropriate therapies early, and a difference can be made. So Duchenne is not yet on the RUST panel, and we'll talk about that a little bit more. Part of the problem is we need a little bit more data on the optimal screening algorithm, and we'll talk about that as well. And then I'm very excited, I was very excited to listen to a presentation yesterday about a 4-month-old being treated. We need to convince this committee with hard data that it is important to start therapy early and that it can make a difference. And that's sort of the first step, and there will probably be more of that coming, and that's going to help this effort to get DMD on the RUST panel. I point out another similar disease supported by another similar organization, Cure SMA, spinal muscular atrophy. It's had a great success story. Again, an ASO therapy was developed, newborn screening was piloted in a bunch of places, and now it's done everywhere, and a therapy is available. It's a little more important for this therapy to start early. If it doesn't, the problems start much earlier, and that's a bit of the problem with Duchenne, since children are not typically detected till 3 to 5 years of age, but that doesn't mean that starting the therapies earlier wouldn't be of great importance. So what's DMD newborn screening? Well, as I just said, in the US, about 600 boys are between age 3 and 6 are diagnosed. But by this time, irreversible muscle damage already occurred. And it is my belief, and I think this is going to be shown, that early and accurate diagnosis is going to be a critical component of optimizing care. Muscle biopsies, before the availability of genetic testing, were the major way that we made the diagnosis of Duchenne. But CK, or creatine kinase, a muscle enzyme that gets released when the muscle is damaged, and is known to be elevated in DMD, is also a way to make diagnosis. Unfortunately, it's not completely specific for DMD, so having a high CK level in a newborn baby or a young child could be another neuromuscular disorder, or it could just be activity that the muscle has transiently elevated the level. And going through the birth process does actually have some stress on the muscles associated with it. So newborns are born with a little bit higher CK level, and then it quickly goes down. If you do have Duchenne, the level is going to stay high over time. And then genetic testing, you've sort of heard a lot about that over yesterday. We can actually sequence the gene and focus in on exactly what the sequence abnormality is that's causing the problem. This information is actually extremely important to choosing the right therapy, as about a third of patients currently might have an exon skipper that's appropriate. 2/3 do not, and you need to know that before the therapy can begin. So the process here is a muscle that's damaged in a Duchenne patient. We used to do the muscle biopsy, but now we can take a blood sample. In this case, I'm talking about collecting it on filter paper, dry blood spot. It goes to a laboratory, and there's now an FDA-approved test for creatine kinase that could be performed in newborn screening labs. And if that creatine kinase level is elevated, then we can extract DNA from that same little dried blood spot. We can sequence it on a sequencing machine, and then we can know that the sequence of the DMD gene that makes dystrophin is either normal, or there's an abnormality that might cause either Becker or Duchenne. These little spots are sort of a timeline of newborn screening, starting back in 1963, and in red, I've pointed out landmarks in Duchenne. So in 1975, the first paper was published on using CK for newborn screening for Duchenne. So almost 50 years have gone by since we have been able to do newborn screening. But remember I said there needs to be a clear therapy for newborn screening programs to justify adding the disorder. The gene was identified in 1986, then making the possibility of adding DNA to the mix for diagnosis. In 2012, an important study from Ohio was published, another pilot very similar to mine, where tens of thousands of babies were screened with CK, and if the CK level was elevated, they were able to do DNA sequencing, and that pilot showed that it was a proof of concept that this was a doable thing. Then the game changer is sort of 2016 when the drugs start coming. First Flazacort, but then all the skipper drugs. And now we have a screen that can be done in a newborn screening laboratory, and we have therapies that are important, and we think they're important to start them early. So there was a submission last year based on all the data that was available, and this Cure Duchenne pilot I'll tell you about contributed data to go to that RUS federal committee to say, could you please add DMD to the panel of recommended disorders? Unfortunately, the panel said, no, we're not ready yet, and this is very common for them. Most disorders have not gotten through on the first pass. They want more data. They want to be convinced that starting early therapy is critical, and that the assay we use to do the screening is robust. And so this pilot is contributing to this effort. This pilot supported by Cure Duchenne. So again, the elements of this screen are that little red spot. That's all the blood we need to take a healthy looking newborn at 24 hours of life. We extract the creatine kinase, measure the level. We still would argue about exactly what the algorithm should be. In other words, what number on the CK should the cutoff be? Should we repeat it right away? Should we repeat it in a month? Should we do a DNA test right away if the first CK is elevated? Those are the types of things this RUS panel wants to know more about. So then with the DNA sequencing, you can do that lots of different ways. Now you could just look at the DMD gene. You could look at a panel of a number of genes, because other neuromuscular diseases caused by other genes do cause the CK to be elevated in the newborn, or potentially you could sequence all the genes and just look at the DMD gene first and then look further if you needed to. Our program chose an algorithm which is the one I believe is the most efficient, fastest, easiest, and least stressful to families. So I come to this again from my perspective with 20 years of cystic fibrosis newborn screening research. There are always false positive tests on newborn screen. The word screen is almost equal to false positive, because you usually set your cutoffs in a way that you don't want to miss anyone who's negative, but who's positive, but you also don't want to have so many false positives that you're calling a lot of families in to say, well, we think your baby might have this problem, we want to do some more tests. Causes an enormous amount of anxiety, and depending on how long it takes to do those tests, that may go on for weeks or months before the family can feel comfortable that it was a false positive, it wasn't really Duchenne. So I believe that this, on the same first dried blood spot, we can measure the CK. We can also measure the DNA in what's called a reflex manner. So if we're above the cutoff, the sample goes right to the DNA lab and they start sequencing. And then if there is no abnormality in the DMD gene, the patient does not have, the baby does not have Duchenne, and we can dismiss them. So being a little more specific, how can this newborn screening contribute to better outcomes for Duchenne children? First of all, I do strongly believe in optimal outcome with early diagnosis and therapy. So we're delaying the implementation of our standards of care. There are also missed opportunities for participating in some of the amazing clinical trials you heard about yesterday. And as we're waiting, those muscles are being damaged, and we're missing the opportunity to try to at least arrest that. There are also other implications, which newborn screening strictly is not interested in, but I think you as families are interested in, that are called diagnostic odysseys. So what went into making the diagnosis for your child with Duchenne? How long did that take? How long did you go to the doctor and say, something's not right, could you do something? These diagnostic odysseys are long, they have a big impact on families, they're costly, and we can avoid that with newborn screening. We also miss the opportunity to help the family plan for a future family if they know they have an affected child. So early identification, I believe, is important. Newborn screening can do that, and we have interventions that we can start right away, maybe the most important and simple of which are things like early intervention and support services that can come to the family. And the drugs, they are developing. So we do have some information that earlier initiation of therapy for those therapies that are out there now does help improve outcome. And we're going to try to push these dotted items on the bottom to the RUSP committee to say that this is why we need to add this to the panel. How does it work at Brigham and Women's Hospital, where I work? So I originally approached Deborah Miller with this idea, and she's, as in every other way, has been very forwardly thinking. I convinced my colleagues in the hospital where I work, we have about 7,000 deliveries a year, that there were enough data out there for us to do this, and we do not have to wait for the RUSP or the state to say, let's do this. Cure Duchenne supported me in doing that. We set up a program. We published within a few months of what we were going to do, and we became the first, and we are currently the only hospital and actually the only place where parents are offered free DMD newborn screening when their baby is born. This is our process. We have a welcome packet that goes to every couple in the postpartum floor after they deliver their baby. In it is a little brochure, you'll see it at the end, which says what Duchenne is and why we are offering them this testing. Also, our pediatricians who meet with the family before the baby goes home explains this offer to them. And then they have a choice of doing it or not doing it. About 80% of our families say yes. If they say yes, at the same time the dried blood spot's being collected for the state newborn screen, we collect a second dried blood spot. We sort of piggyback onto that process that's in place. And then we send it to a lab that does the CK, and then to a lab that does the DNA sequencing if that's elevated. This is the algorithm, not going into much details. We have numbers that we cut off and decide whether to do the DMD sequencing. The results go back to the family through the electronic medical record. And if on the DNA sequencing we find an abnormality in the sequence in the DMD gene, we call that a screen positive. We bring the family back to a special follow-up clinic that we've developed at Children's Hospital in Boston that's specifically designed to take in asymptomatic newborns with a diagnosis of Duchenne. So far, and these numbers are a little old, but we've just this week surpassed 10,000 babies that we've screened. Of those, we've had around 250 babies with elevated CKs that went to DNA sequencing. Those false positives that I've told you about, so we have had, with these numbers, we had 8 false positives. We have not yet detected our first baby. We've been doing this for about 18 months. Not that I want to detect a new baby with Duchenne, but this is our proof of concept that our program works and we can pick up an unknown in the sea of babies that are being born. You're going to hear from the next speaker about carriers. Most of these are females. 4 of them had definite mutations that would, if they had a child, when they could have a child that was a male, would cause Duchenne. Some of them are what we call VUSs, or we don't know the significance of this sequence variant, and that's going to be a problem with this that needs to be sorted out. And again, the sort of thing that we will have, we currently have the most experience of any of the pilots that have been done in how to approach these families. We currently bring them back to the follow-up clinic, let them meet with a genetic counselor, and the neurologists keep an eye on them because females do, in their later years, can have problems with both muscle and cardiac issues. This is very busy, and I'm not going to talk about the data, but just to let you know that also uniquely, we have been able to collect information through the electronic record tied to the CK value on all the reasons why false positive CK elevations happen. Things that have to do with race, weight, whether the baby is breech, whether the baby was delivered by a C-section or vaginal delivery, whether there was a resuscitation in the delivery room. We're analyzing all these factors to be able to look at what things we might correct for so that if we do have positive values, we can counsel the families appropriately and tell them why we think that initial CK was elevated. So where we think this is going over the next years is my hospital has 7,000 deliveries. My healthcare network has 3 other birth hospitals. Together we have about 17,000 deliveries. We are trying to expand to the MGB healthcare network, and then we're in the process of trying to present this to our state to add DMD to the state newborn screen as a pilot. And if all of Massachusetts babies are getting this, that's about 70,000 babies a year. So I'm aiming to get from 7,000 to 70,000. And if Massachusetts does it, those other states are going to want to do it too. And we will also be gathering more data to be able to go back to the RUSP and say we need to be doing this. So thank you, Cure Duchenne, for supporting this. We're going to go back to the RUSP. We're going to have another shot at doing this with some more data. And thank you all for listening about newborn screening for Duchenne.
My mic's on. All right. I know some of you. So I used to be at UT Southwestern Dallas. I'm now at University of Kansas. These are my disclosures. All right. Oops. So for the last 25 years, I was in Dallas, and I love the Longhorns and the Mavericks. But 2 months ago, I moved to Kansas, and now I'm a Jayhawks and a Chiefs fan. But my love is actually Wisconsin, where I was born and raised, and so I'm a cheesehead through and through. So go Wisconsin. All right, with that said, I'm going to talk about DMD carriers and the cardiac care that we offer to carriers. These are some of the questions over the next 15 minutes that I'm going to try and highlight, and we'll go through some of this here. So the next couple slides, I'm going to go over a little quicker. Richard kind of went over that, but this is my sense of why carriers should be screened perhaps earlier. So carriers in general may develop an isolated cardiomyopathy without the peripheral muscle weakness, and it's believed due to this concept of X inactivation, where females have two X genes, and you have the dystrophin gene on one of the X, which is mutated. But in the heart cells, for whatever reason, the wild type X is silenced, and so the heart cells often behave as a full DMD patient where they develop a cardiomyopathy. So the question has always come up to me is, when to screen DMD carriers, and ideally to perform genetic testing as early as possible, because there are many therapies that are down the road, including CRISPR, that is going to really change the course of this disease process. From a heart standpoint, it's hard to know. If someone is having arrhythmias or heart failure, you should screen them. Otherwise, I would say late teenage years is usually, from a cardiac standpoint, the best time to screen them, because we do have therapies that can change the course of these women. The other issue is about pregnancy. So I have about 4 DMD carriers that have actually got pregnant, and I send them to our genetic counselors. And through fertility experts, they're able to have healthy children where they are able to exclude the genetic mutation in the eggs that carry it, and they've had very successful pregnancies. So cardiac abnormalities in DMD carriers. So the Italians were very perceptive about this. So this is a study that was published almost 25 years ago, a very crude study looking at the prevalence of carriers and in both Duchenne's and Becker's. And in their cohort of about 200 patients, as expected, about 2/3 were gene deletions. And when they broke them up into those patients who were 5 to 15 and those older than 15. And if you look on the right-hand side, those younger than 15 years old, there weren't that many that were identified as having cardiac abnormalities. While those older than 50, almost 50% of these women had some type of cardiac abnormality, whether they were arrhythmias or frank heart failure. So fast forward, a British group about a couple years ago also looked at their DMD and their Becker carriers. They looked about 130 patients. The average age was about 39. And they used echo as a criteria to look at cardiac function. And in this cohort, about 14% actually had dilated hearts, which is one of the first signs that the heart is injured and is getting weak. 13% had low EFs, less than 55%, while 3% had lower than 40%. And in 2021, a Danish group looked at their cohort of Duchenne's and Becker's patients. It was a small study, 53 patients, a little older population, about 50 years old. And in this population, about 62% actually had abnormal cardiac events by echo. 50% of these patients had myocardial fibrosis by cardiac MRI. 35% had dilated hearts. And almost 72% had some type of arrhythmias as identified by EKG or Holter monitors. And in their study, this is kind of identifying kind of where these cardiac abnormalities were. So if you look on the right-hand side, those are arrhythmias. You know, there's a significant number of older women that have significant arrhythmias, whether it's SVTs or rhythms from the top two chambers of the heart or rhythms from the bottom part of the heart. So how do we take care of these patients? So the next few slides are protocols that I've developed over the last 10 years. So when a female carrier comes to my clinic, I screen them from a biological standpoint. I look at their cardiac and inflammatory biomarkers. I get a sense of what their submaximal exercise capacity is. And I also do a more formal cardiopulmonary stress test. If there is any signs of arrhythmias, we look at a Holter or even a 30-day event monitor. And I image almost exclusively by cardiac MRI. So why MRI? You know, 80% of what we do in cardiology and echo is all that's needed. But it's turned out that cardiac MRI is really the gold standard to image almost anyone with any type of muscular dystrophy, in particular in Duchenne's. It's a lot more sensitive. You get a good look at the right and left ventricles, and you're able to detect fibrosis. The downside, it is a little more expensive, and it takes about an hour to do a full, adequate cardiac MRI. So this is some data from our group that we're working on getting published, where we looked at the Dallas Heart Study in terms of our control population. And then we divided our carriers between those with preserved ejection fraction and those with reduced ejection fraction, as defined as an EF less than 60%. And you can see here, we looked at how big the ventricle is, the end diastolic volume. We looked at ejection fraction. And we looked at this concept called LV concentricity. Normally, LV concentricity goes up when you have heart failure. You have pathologic hypertrophy. And you can see on the right-hand side that these women actually had smaller hearts and perhaps even more atrophy. And their ejection fraction, especially those that had lower EFs, was significantly lower than our control population. And they were very dilated. And like some of the other studies, about 60% of our cohort had myocardial fibrosis, whether they had preserved ejection fraction or reduced ejection fraction. And this is important because we do know that if you develop myocardial fibrosis, that down the road you're going to be, have more risk of developing arrhythmias and LV dysfunction. Before I move forward, I do want to make this comment about, you know, many of the carriers who come to me have no symptoms of what we call heart failure. They have maybe a little bit dyspnea, but they don't have signs of clinical volume overload. They don't have difficulty when they sleep. They don't wake up short of breath. And so when do you start treatment? Because we do have treatment. So this is from an old study called the SOLVE trial back in the 90s, where we looked at all comers with cardiomyopathy, whether you had a heart attack, high blood pressure, and they looked at the role of enalapril, which is an ACE inhibitor, versus placebo, meaning sugar water. And the reason I'm showing this is I want to highlight those that were on placebo. So these are individuals that had low EFs, lower than 40% by echo, had no signs of heart failure. And you can see the risk of death or heart failure or the mortality was much higher in those in placebo, highlighting the need to start treatment as soon as we identified that there's any LV dysfunction. Oops, I'm going to pass that up. So what's our treatment here? So if someone comes in with some LV dysfunction, those therapies in red are really the mainstay of how we treat them. Beta blockers, ACE inhibitors like lisinopril and enalapril, and aldosterone inhibitors, spironolactone, Plerinone. So people also ask about exercise and what's the exercise capacity and can I exercise? So this is a study from Nationwide Hospital, published about a couple years ago. What I want to highlight here is your peak oxygen consumption in this group. So how much oxygen do you use at peak exercise? So our DMD carriers are on the I guess your right, or left. And then they had 2 control groups, both non-carriers and a control healthy group that they identified. And they didn't see a huge difference in terms of peak oxygen consumption. But their MRIs, there were some differences. There was more myocardial fibrosis in this group. Their cohort, though, was a younger cohort. They were about 40 years old. So we repeated it in our cohort, comparing our patients to the Dallas Heart Study. Our cohort was a little older, closer to 50 years old. And a couple things I want to highlight here. Both those with preserved ejection fraction, those with reduced ejection fraction, had a lower resting heart rate. Their peak heart rate was actually lower, so they weren't able to achieve the same heart rate as the control population. And their peak oxygen consumption was not significantly different, but the rate pressure product, how much work could they do, was actually lower. Was actually lower compared to the control group. Now, all these women were not marathon runners. They were just this was de novo exercise training. So, how much exercise is too much? So, usually, what I do recommend is doing some type of aerobic exercise for about 30 minutes to get your heart rate about 80% of predicted. And a question that's still not clear is, can you improve your exercise capacity by training? And what type of exercise do you do? I think ideally things like water aerobics or brisk walking are the ideal forms of exercise. Fortunately, I do have some women that are marathon runners and weightlifters, and I do caution people to doing that because you have repeated myotrauma if you do excessive exercise. And you may not see what happens with excessive exercise until 10, 20, 30 years down the road. So what are some of the future aspects of cardiac care in DMD carriers? You know, unfortunately, there are very few out there that have devoted their careers to carriers and Duchenne's and Becker's. But there are few, and we have to develop platforms to collaborate and pool our data. There's Andreas, who's an EP physician at Hopkins, who runs the inherited cardiomyopathy clinic there, forms a heart failure cardiologist at Minnesota. I run both now the programs at Kansas, and I still have an affiliation with UT Southwestern. Teresa Wang is a heart failure cardiologist at Pennsylvania, and Matthew Wheeler is here at Stanford, who also runs a clinic devoted to dystrophy. There clearly needs to be a lot more education for cardiovascular issues related to DMD carriers among the community cardiologists, and many of us in our position are giving talks to our colleagues to try and educate them and why it's so important to screen carriers by MRI and take them really seriously. And there clearly has to be more research dollars from the NIH to study these cardiovascular events. You know, if you develop at an early age, does it progress, right? And if you have a normal MRI in your 20s, when you're 50 or 60, can you develop further heart failure? We don't know these questions. There are a lot of unanswered questions. So with that, I'll end. So this is my new group here in Kansas City. So if those of you who have not been to Kansas City, it's a beautiful city. My contact information is down there. And I would be amiss if I didn't mention about the UT Southwestern Wellstone Center. Both Dr. Olson and I still run the Wellstone Center, and our goal is to take CRISPR to the next level. And really, it's under Eric's leadership, but I also work with him still. So with that, I will turn the podium over.
Perfect time. Hello, everybody. Thank you for having me here. I'm going to start saying I'm Diana Castro. I'm the proud director of the first Cure Duchenne clinic in the country. Big applause for that. Proud because I came from university. I left the university. I used to work with Dr. Mamin, but I left because there are many gaps. There are many things that we need to work on, and this is what I want to show you today. I don't want to say just the negative. I want to say it. I want to put it out there for you guys to help me finding ways to help people better. I also work with the CARI Foundation, which is a foundation specialized only for Hispanic patients with Duchenne, who has been amazing, who has providing me a door to reach out people, like for example, people in Puerto Rico. I just came from there, I was the first doctor that went to talk about Duchenne in Puerto Rico, and it's our same country. So let's start with gaps. So the current gaps in access is access to appropriate specialists and clinics. The problem is that there are many, many clinics all over the country. The problem is, what is the quality of care in these clinics? The ideal, yes, is to have a multidisciplinary team. The idea is to have a cardiologist, a pulmonologist, everybody else. It's not that easy for everybody to have those services. But that causes people and puts the patients onto having to travel big distances to get to other sites where they are going to find that care. And the problem is that those travel, it's limited by your economic situation, right? If you don't have money to travel, you're not going to go everywhere. If your son starts getting older, travel starts getting more difficult. So this is a big, big issue. That also reflects in access to pharmacologic treatments and to the correct standard of care. Access to appropriate therapies and equipment, emotional and psychological support, I will mention that at the end, and we have Natalie here who will talk about us. And then uninsured and really underinsured people. When I started doing this, I thought I was gonna have a big number of uninsured. It is actually, the biggest number is underinsured. Because it doesn't matter if you have Medicaid, but your Medicaid doesn't cover anything. For what? Yet you have Marketplace, they don't cover anything. So that's what I'm seeing is the biggest issue right now that we're having. Language and cultural difference. I'm blessed I was born in Colombia, I speak Spanish. That's my first language. Not only I speak, but I understand the culture. And I think that every clinic that has the capacity to have somebody who actually speaks and understands the culture will offer much, much better services for those patients. Transportation, appointments, care for siblings, there are so many things that are in that area. I keep telling the story recently that I felt really dumb because I have this family with twins who came to my clinic. I know them for many years, and they came pushing, my mom came pushing two manual wheelchairs by herself. And I say, Mom, I gave you power wheelchair. And she said, yes, Dr. Castro, but I don't have a van or a car where I can put the power wheelchairs. I feel so dumb that day because I'm not helping the way I should be helping. I cannot just throw all the equipment. I have families that say, yeah, we have the medical bed, we have the other thing, we have the other thing. It's all in storage because we don't have where to put it in the house. So these are the things that we have to start paying more attention as physicians. Why do these barriers exist? There are not enough people specialized in what I do. And not only that, there is no time. When you're in an institution, it's about numbers, and it's about getting people in and out. 10 minutes, 15-minute appointments. Are you kidding me? I'm not gonna see a Duchenne patient in 15 minutes. It's not gonna happen. And if I do that, I'm providing a really bad service. One of the reasons I wanna leave the institution, because the institutions are run, and I'm sorry, but they're run by people that don't understand these conditions. There are administrators that they never took the time to come to my clinic in 10 years at UT Southwestern to come and see how my clinic was going. And that is the big issue. High-cost therapies and insurance limitations, yes. I mean, we have so many insurance that come to me and they say, this is an experimental medication. I'm like, no, this is not experimental. Jesus Christ, they approved it 3 years ago and it's not experimental. And I'm Colombian, I just say it straight. So, and because really, are you really that, oh, it drives me crazy because they don't even take the time to read through what they have to read if I'm requesting a medication. Lack of therapies, specialized and bilingual. Again, it's important to have because having a person translating is not the same as talking to them in their language. Sometimes I'm speaking to my Spanish speaker families, they don't understand what I'm saying. And I swear it worries me. I'm like, I've been here 20 years in this country. Maybe I'm not speaking right anymore Spanish. But it's not that. It's a lot of information. It's very hard for these families to keep up with everything. You cannot pretend that you're going to go to the first visit and you're going to learn everything about Duchenne. It's a process. Most psychologists, equipment is expensive, sometimes cannot use, like I just told you about this family. Most psychologists and psychiatrists are out of network cash pay. I tried to hire a group of psychologists to come to my clinic. And I thought, well, they understand we're nonprofit, you know, they'll give us a good price, $250 per hour. I cannot afford that right now. I do have a service from a Cari Foundation where they have a psychologist who is seeing some of my Spanish-speaking moms. They offer 10 sessions for free for those moms. So I just refer them to the foundation and they take care of them. I need that. So if whoever here is a psychologist and want to donate time, please, we need that. So why do these barriers exist? Again, limited access to insurance, and the reality is that it doesn't even matter. Insurance are really hard, and it's a fight. We have to fight with them every day, but we'll keep fighting. It's just, I wish there was some guidance for people. Some people ask me, what type of Medicaid should I get? I'm like, I don't know. We need to have somebody paying attention to say, hey, get this in this state. Don't get this insurance in this state. This one is going to help you. This is not going to help you. So that's why I have been driving Leslie Porter crazy, because all the moms that I have right now are like, don't worry, I'll introduce you to this mom that knows everything. So she's my social worker, not a social worker right now, but she's awesome. The federal poverty level threshold to qualify for Medicaid has been a big issue, and unfortunately not proud, but Texas is the worst state in the country. So if you have, for example, I have a family who was getting, they had Medicaid coverage, but then that got a little raise. And I'm talking a little raise like $3,000. For that, they lost Medicaid. So if we have these limitations, then what's your option? Getting a marketplace insurance, which is going to be very expensive and which is not going to cover anything. So the federal poverty level threshold to qualify for Medicaid by state for a family of 4 is $30,000. The problem is that it differs by state. So DC is 221%, California 138%, and Texas 16%. So if you get too much, that is really not too much. You don't have coverage. That's it. So unfortunately, one of the biggest issues in my state is that it doesn't matter you have one insurance if it's not going to cover anything. So how can we begin to solve these issues? One, educate and make more people start loving this, because this has a lot to love. This condition, these parents, this group of people are amazing, and this is my love, and I wish more people had the love I have. No, really. Because you guys have it hard. And if we're in a better situation like physicians, and we're in a situation that can help you, we should be able to help. And when I'm trying to reach out to find, for example, I have a group for cardiologists, a pediatric cardiology group. I have 3 of them. I've been trying to find an adult cardiologist. And the answer is, that's not enough revenue for me. You know how sad that makes me? I did not go to medical school because of how much I was going to get. I did go to medical school because I really want to help people. And we really need to find these people. Educate insurance and about the medications that are approved. Don't waste my time trying to explain to you something that you should know, because I don't have the time. Policies for coverage. There should be something standardized that every company can use, something that all the companies get together, and we're going to talk about excellence keeping. So then it's taking time. You know, it will take my load of work. Educate and incentivize therapists to learn motor skills. There are many therapists that are really interesting, but then they don't find where to get educated, where to get help. Recycle equipment. This is something, another of my pains, is that, for example, I'm working with New Motion, we're trying to set up a closet. But then they tell me, but you're gonna have to pay a fee. I'm like, why a fee? Because it looks like we are giving you an incentive to work only with us. I'm like, I don't care. Just put the equipment somewhere, try to fix it, and then I can give it to somebody else. So there are so many layers and rules and things that I do not understand, and I really don't care. But if I have a family that wants to donate an equipment, help me finding a way for that other family to get it, because we need that. I have one of my patients who came to the opening of our clinic, and he was sliding from the chair because he didn't have feet. He didn't have the pedals to put his feet. The chair was extremely small. Like, these are the things I don't want to see. If any of you have one wheelchair at home that are not used anymore, so why we cannot recycle these? In my country, a wheelchair probably gets recycled 10 times because we're poor. So you have to do it. But here is like, you have the money, you have the equipment, but then let me put all the rules to make it very difficult for you to use it. Create transportation programs and stipends to help parents with other siblings. The families are busy and they have 5 other kids, 4 other kids. They have to take them to school, and then I'm asking them to come to clinic for 3 hours. We need to help these families. So how come we, another part, I don't know what to do about psychologists and psychiatrists. We have to clone you like 100 times because there is no money for that. But one thing that we're thinking is to create a support group for some of the kids. Again, we need psychologists for the mothers. Create nonprofit clinics, yes, like us, where we can use sliding scales. So we're taking patients. I don't care about your legal status or not. I don't care if you have insurance or not. We'll see you. We have a sliding scale that we work to try to make you pay the less we can, and that is thanks to Cure Duchenne. And and then trying to find social workers and people that knows all the loopholes, because I had a family, for example, who came and said, we got Social Security for my 21-year-old, everything perfect. And then I had the next family who said, we applied for Social Security and we couldn't get it. And it was a 21-year-old, exactly the same situation. They were from Denton, actually, both of them. So what changed between one or the other one? One family used a person that knows all the ways you have to submit the paperwork to get it. So they have a consultant. So they pay $150 for a consultant, and that's how they got the Social Security. So we need people with that knowledge. What is the benefit of expanding access to good care? Good care is cheaper. If I take an hour with you, I'm going to answer your questions. I'm going to prevent you from having to come to the hospital so often. You're going to have less problems that are unresolved. We're going to have better communication. I'm going to have time to see you, to know you. And it's better mental health. Sometimes I feel what I'm doing in regards of the muscle is not that important. Sometimes I'm doing a lot of the talking, tell me. Let's just sit and talk about your situation. And I think that's more powerful than anything. Benefit also to expand research. In our side, for example, I have a research area. So we have half of the company is a nonprofit and the other one is for research. And the idea I wanted to have research was to be able to put patients on research trials. So if the patient comes to my clinic, I put them on a database. And if there is a trial that will be applicable for that patient, I'll try to put them right away. Why? Because the research will cover my cardiac MRI, will cover the PFTs, will cover all the things that I need to figure out how to get covered. What can be done? Again, teach people, get people excited about these. We need more Dr. Mamens. He left Texas, and I don't know what I'm going to do now. I have moms every day asking me for a carrier clinic. I would love to have a carrier clinic, but I need a cardiologist. I'd love to be able to start doing a physical exam for the moms, but I need a cardiologist next to me. More specialized social workers that can help patients with all of these: transportation, insurance, medication, psychology support, and then legislation. This was the opening. This is my beautiful husband, my 2 kids, and my beautiful patient who are cutting the ribbon. And Carrie's there, and some of my team. And that was one of the most special days I have had in my life. And I appreciate your time. Thank you.
All right, well, I'm really excited to be here with you all today. I'm Natalie Truba. I'm a pediatric psychologist from Nationwide Children's Hospital in Columbus. I am going to talk rather quick. This is not the best title to kind of encapsulate, so bear with me here. But I'm just going to launch into it. I'm going to go kind of fast because I have a limited amount of time and a lot of information that I want to cover, and I like to talk. So, Diana is correct. The nature and the reality of the situation is that we have a huge issue with access to mental health care. Psychological providers that are trained in DMD and understanding dystrophin in the brain and how that impacts emotion and behavior regulation capacity is lacking. We have very few neuropsychologists who have expertise in testing batteries and understanding and interpreting tester batteries in the context of dystrophinopathy. And then we have even less psychiatrists. And we have a national shortage in mental health providers anyway. And then with regards to specialized care for DMD, it's even worse. So it's a big issue and it's a big problem. And this is really problematic when we just kind of step back and recognize that mental and behavioral health are bidirectionally related and very impactful on each other. And so you can't live and survive, and you definitely can't thrive if you're not behaving. So if you think about all the things that you go into finding value and purpose and joy and the things you do with your family, those are all behaviors. It all involves motivation and effort and psychological health and well-being to do those things. And that's important to recognize because the needs of all of us change over time and over the span of our life. And the needs even from early childhood to middle childhood, from young adult to later adulthood are different. And so we have to recognize that the cohorts of boys that we're working with, while they have shared experiences in that cohort, the next cohort might have very different experiences. And so all the planning and all the learning we're doing for each cohort of boys is then leaves us kind of chasing constantly. And so we're not actually planning, we're reacting to. And so we need to start to think ahead and start to predict what are we going to be experiencing and where do we need to start to build infrastructure to prevent unnecessary suffering, trauma, and vulnerability in care. And so if we step back, right, I started getting involved with Duchenne about 5 years ago. And since that time, I've seen just a big sort of flourishing of the interest in mental health and understanding the psychiatric needs and the emotional behavioral needs of kiddos with Duchenne and Becker. And so that's led us to start to understand more of their behavioral phenotypes, right? Like, why are we seeing some of the things we're seeing? How do we start to classify these behaviors that are occurring together? How do we understand their neurocognitive profiles? They tend to have pretty similar neurocognitive profiles, which is, I think, very interesting and should give us pause that something's going on here in the brain. And lo and behold, we're understanding more about brain dystrophin, and boy, does that feel validating from 5 years ago when we first started to talk about these things. And so in the next 5 years, what are we going to see? We're going to see approved therapies on the horizon, and that's going to change the landscape drastically, because not everyone's going to be qualifying for the same types of therapies. So now we're going to have cohorts of boys that, instead of having very similar disease experiences, or now might have very different disease experiences. We might have some boys who are doing much better than other boys. How is that going to impact our community and how we feel as a unified kind of group? And then we look 10 to 15 years, we're going to have even more treatments. And some of those might be for individuals with much more advanced disease progression. What does that mean? What kind of resources do we need then if we are kind of halting or stopping further disease progression and you're already pretty affected in your late 20s, right? That's going to change resources, that's going to change care demands, that's going to change your vulnerability and the ethics that drive care. And so in this reality that we're living longer, right, we need a culture shift. We need a culture shift in the neuromuscular world and preparation that needs to start very early so that into adulthood we are thriving and not sort of experiencing the amount of distress that is currently being felt in our community. And this is not only just from parents and families, but from providers, because as providers, we are modeling what is expectations and how do we outline what is important in care. And if it's not talked about, then families don't know that they need to be thinking about that as an important aspect of care and an important aspect of future planning. Because we want to be promoting mental wellness, right? We have a shortage of mental health providers. It's hard to get linked. And so we don't want to say, you know, let's neglect this until you have so much psychopathology that you are really not okay, right? We don't want to do that. We don't wait to start heart medications when your ejection fraction's in the 40s, right? We start them much earlier because we want to prevent getting to that place for as long as possible. Same with mental health. So we want to focus on mental wellness. What are the things we need to do to be mentally well? Not what do we do when we have psychopathology, right? We've already missed the mark. That's a very active and intentional process. We have to put effort into it, and we need to do it continuously, okay? So we need to be talking about it. So use of screeners, normalizing and incorporating mental health providers, and recognizing that mental health is health. You're not going to improve health outcomes if you don't address the behavioral underpinnings that drive adherence and all the other things that go into being healthy. So, well, that messed up, but whatever. And so through adolescence, through adulthood, a lot of my guys will talk about the shift that it feels for them in clinic. Their clinic visits feel different, right? Because there's less talk about treatments and less talk about some of those gene therapy things, and we start to shift towards, we're spending more time with our pulmonology providers, our palliative care providers, people like myself, our phys med docs, and some other therapy type things, and it feels different. They recognize that. They're like, I'm spending less time with my neuromuscular providers, my visits feel different. And that doesn't always feel good, right? But the goal of that is promoting quality of life. But if we don't talk about that and recognize and kind of preferred scaffolding around that, it's going to feel a type of way. And we want to do better with this. And one of the reasons is because as we start to bring in the adult type needs, we can address the things that are actually really important to adults and adolescents that we're not really doing a great job of right now. Things like sexuality and intimacy. Things like, how do I develop meaningful relationships into adulthood? How do I think about a career and financial stability and independence? How do I live independently, right? What are the skills I need to be doing that? Because at the end of the day, there are real skills that go into navigating that world. And for example, one of the biggest things that I see is a lot of guys will say, my caregivers I've had for a very long time, they're kind of like secondary parents to me. I'm not comfortable like having certain conversations with them. One, because they're going to tell my parents, but two, like it feels like talking to a parent. And so like I don't want my caregiver or my mom to wingman for me at the bar. I get that. I wouldn't want that either, right? But then you have to have a skill set around interviewing people. How do you talk about what you need so that you can actually vet who you're interviewing to try to make sure that your needs are going to be met and how you want to structure what's important to you so that you're living a value-based life. That takes skills. And if those skills are not foundationally put in place early, it's really hard to then do that as an adult. And it's important just to recognize that aging adults have different needs than younger adults, and our men are going to start to live to be aging adults. Some of them already are aging adults, and we don't really talk about aging in DMD. What does that mean? How do we conceptualize that, right? And then their parents are aging adults. That's already real. And so as both of those parallel processes are occurring and we're living longer, that's going to create potentially a huge problem with regards to how are we going to meet the needs of care in a way that it doesn't create intense vulnerability and a lot of potentially unethical things from occurring. And the reason I say that is because I see it a lot. I see a lot of men in situations that got started before they were 18, or now they're 18, and their rights and their autonomy and their ability to make decisions for themselves have been very limited out of the kindness of people's hearts, but in a way now that is really problematic for them to be making their own decisions and engaging in life as they want to. And so when we want to talk about assessing quality of life for yourselves as parents, as providers, because really at the end of the day, how we structure and understand values around decision making, how do you make decisions as a family, as a provider, how do you understand the values that drive the decisions of your patients, is important because the decisions we make now are going to impact the options and the opportunities we have down the road. And we can really limit ourselves by not being very thoughtful and understanding like what is important, right? So sometimes it takes a little bit of guidance to helping get to a place that's like, this might be hard and this might be a growing pain now, but to get to this goal that you have, like we have to do this, right? Because that's life, right? Like you grow through difficulties, and just as Justin and Patrick were saying, easy doesn't mean good, and it doesn't actually normally benefit you. And so these are hard things to sometimes navigate, but they're very important things to navigate. And so those foundational skill deficits are just so incredibly important to identify early and make part of routine care, right? So if you have a kiddo who really struggles to initiate or engage in conversations, that is something you lean into hard. And I see a lot of parents who lessen those demands on their kids, right? Because it's hard for them and they already are dealing with a lot, and I don't want to put them in other situations that they already don't like. But if you think about how you raise your other kids, if you have a child who hates math, you don't throw in the books, you're like, you don't have to do math anymore, don't worry about it. You're like, we're going to sit down, we're going to take more time, and we're going to work through this because this is hard for you, right? Because it's something that you know is important and that you need to know in order to continue to progress through school. The social things for these boys are just as important, and something that we really need to step back and say, are we really pushing and addressing the things that we need to be functional adults that can live on their own, that can navigate these things, that can, live a thriving, not just surviving, but a thriving adult life. And by focusing on quality of life, what we do is we start to shift this conversation about what's needed, what's important, what do we need to start to be thinking about, okay? And so again, we want to start early and we want to model what we want to see. So for my providers out there, the earlier we outline expectations, we start to talk about these things, the more foundational growth that we're going to be able to create, and we're going to help our parents actually know where they want to springboard from. What are we doing and why are we addressing these things in this way? Because we're trying to get to these goals. I want my son, and my son wants to be able to go to college, wants to live independently, then we might need to address some real gaps in how we are able to do that early, because it's really hard to do once you leave high school. A lot of infrastructure is gone once you leave high school. So anticipate those problems and talk about it. As a family, as a parent, talk about it. As a provider, talk about it with your families. Talk about the impact on siblings. Talk about how you think about the concepts of fairness and justice, right? Like fairness doesn't mean everybody gets everything the same, right? We can talk to our kids about looking at fairness, cross that out, more like equity and justice. Or people get what they need, right? It's not fair to have DMD, and you have different needs when it comes to DMD, right? And so we need to be able to create this language and talk about this so our siblings are not experiencing as much suffering as well. And at the end of the day, we need to be advocating for more infrastructure to support quality of life. So my ask today to all of the industry members in here is that as you guys are developing your amazing gene therapies and other adjunct therapies that are going to be life-changing over the next 5, 10, 20 years, one of the things I ask is that businesses, out of the goodness of your heart, you're doing a lot and you're eating a lot of costs. But there would not continue to be if there's not going to be some benefit financially to you as an institution, right? That's just the nature of how business works. Is there a way that we could look at resource development to build infrastructure for these families that we are helping live longer into adulthood lives? Do we have the correct places for residency that people can live independently? Do we have pools of funds for caregivers so that we can pay and have good nursing staff and good aid staff? Do we have the appropriate infrastructure to promote actually educational opportunities and doing the things that we need to benefit so that we can live independently? Right now we don't, and those are going to be very expensive. And so the other side of the coin of doing all the things we're doing to promote longevity is promoting longevity in a way that also sustains quality and allows for not just being alive, but living life. And so we want to be proactive because that's where we're going to maximize. So one of the things that I think is really important and that we've started talking about are what are the things that we can do to give you time back in your day. And so we have a lot of young men, and not when we're actively declining. We're looking at end of life. We're talking advanced care planning. Not when we've had poor follow-up for years and we're emaciated and our bodies are failing, but way before that, right? So when you're in clinic and if you're a parent and you're like, man, we spend 3 hours a day just doing feeding type stuff and a couple hours a day toileting, that's like 5, 6 hours a day. That's your hobby, right? And then we're like, why aren't you getting out and like living life, my dude? He's like, well, I did. I lived life like at 4 a.m. so I got up so I could go to the bathroom because my dad is the only one that can help me. And he has to go to work at 5, so I get up early to do that. And then I try to go back to bed, and if I don't go, then I know I'm not gonna be able to leave my house today because I'm not willing to go longer than 20, 30 minutes away from my house because nobody has Hoyer lifts. Nobody can help me get out of my chair. If I have an accident, then I'm just sitting in that. I don't want that, right? They're full-blown men. They don't want that, right? And then you think about eating and feeding, and that can take a significant amount of time, right? So why aren't we talking about things like elective ostomies and G-tubes to give time back and to promote quality? Why aren't we talking about things like Mitrophanoffs? It's so much easier to be out at the bar with your friends, and if you need to go to the bathroom, to have a Mitrophanoff than it is to talk to one of your male friends about helping you use a urinal or something like that. And so being more thoughtful about how do we actually get time back so we can build quality, I think is incredibly important. And again, not when we're moving into end of life, but much, much, much before that, right? And so I challenge all of you as parents and providers to maybe, if we could step back and think, what are the things that we already have available to us that might be really helpful in promoting quality of life, independence and autonomy, and the ability to actually get out more as young men without, the need for constant parental involvement or supervision. Please do. That's my major ask today. Thank you.
Say thanks to all these speakers. The thing about Trailblazers is that it shows some challenges that we have and some places that we still have to go. And I happen to be a mom who started out my journey with advocacy, sitting in a room just listening to this stuff. So all of us that are learning this journey can be part of filling these holes that we need to get to the next step, because we can all get there together. And I mean, hearing that keynote together, if it's just because it's challenging doesn't mean it's not worth it. And together we really can do this stuff. But thanks so much for sharing that and for being here. So I'm excusing you guys and we're going on to the next one, but thank you so much.
Okay.